Hello, my name is Osama Naga. This short presentation is about Pediatric Dermatology Board Review. You can follow with me in the Pediatric Board Study Guide from page 491 to page 505. Before we proceed further in this presentation, I would like to give some definition commonly we'll use to describe skin diseases, different skin diseases. The first one is macule. What is macule? Macule is a flat lesion with a change in skin color. Papule is a solid raised lesion less than 1 centimeter. Nodule, similar to papule but just larger in size, is a solid raised lesion more than 1 centimeter. Plaque is a solid raised flat topped lesion greater than 1 centimeter. Vesicle is a superficial lesion, raised lesion filled with clear fluid less than 1 centimeter, so it's a small. Bulli is similar to vesicle but just larger in size, and raised fluid filled lesions more than 1 centimeter, commonly seen in patients with burn. Pustules is elevation or elevated lesion that contains purulent or cloudy material or pus. Abscess is a deep tissue infection, localized collection of pus in a cavity caused by tissue disintegration or tissue necrosis. Wheal is area of edema in the upper epidermis, varies in size from small to larger blotchy skin changes, and usually pruritic and commonly seen in cases of urticaria. Burrows is a linear lesion caused by skin infestation, commonly seen in the patient with scabies. Lichenification means the thickening of the epidermis, commonly seen in atopic dermatitis or eczema because of frequent scratching and itching. Excoriation is abrasion of the skin, or a punctate or linear abrasion, which is injury to the skin because of itching and frequent scratching, commonly seen in cases of eczema. I will start with skin disorders in neonates. Let's start with this clinical case scenario. This is a figure of a 3 days old boy with blotchy erythematous macules, which is a flat lesion, to remind you, and the plaques with multiple papules, which is solid raised lesion, and a few pustules like vesicle filled with purulent material or pus. So what is the most likely cause in a 3 days old presents with blotchy erythematous skin lesion and a few pustules? This is a classic presentation of erythema toxicum. It's very common and you need to be familiar with it. Erythema toxicum is a benign self-limited condition, very common to be seen in newborn infants and requires reassurance. The onset in the first or second day of life presents with discrete erythematous blotchy macules or patches, each with a central papule, vesicle, or pustules. It may cluster and form erythematous plaque. The rash here is filled with eosinophil. This is important and I like to ask about this in the board exam. The process lasts a week or less. If it lasts longer than that and doesn't go away or start to go through stages, you may think about incontinentia pigmenti, especially if the presentation in a girl. Of course, incontinentia pigmenti is incompatible with life in boys. Management is reassurance. This is a newborn boy presents with multiple pustules in the face and the body, and 10 days later these pustules start to be macules with hyperpigmentation. So the key word here, pustules after birth in the newborn period, and later on these pustules start to change to be macules with hyperpigmentation. What is the most likely cause of this condition? This is a classic presentation of transient neonatal pustular melanosis. From the name, transient means benign, self-limited. Neonatal presents after birth. Pustular means pustules and followed by melanosis or hyperpigmented macules. The cause is unknown. It is a benign condition, usually resolved in several days. Clinical presentation: superficial pustules appears in the face and the body, followed by pigmented macules in the skin. Presents at birth. The brown macules may persist for several months. The rash or the rashes are filled with, or these pustules or this cloudy material is polymorph nuclear leukocytes without organism. So if you do a gram stain, will show no organism, but just leukocytes or white blood cells. And in the cases of erythema toxicum, remember it is eosinophil. In cases of transient neonatal pustular melanosis, is filled with polymorph nuclear leukocytes. The management is reassurance, no cream, no antibiotic, just teach the parents about the course of the illness. Common benign newborn rashes, very important to be familiar with. The parents always will ask about these rashes and will ask if this is normal, and also is very common on the pediatric board examination. The first example of the common benign newborn rashes is salmon patch. Salmon patch is a pink patch, appears in the middle or commonly appears in the middle of the forehead, and is well known also as nevus simplex or angel kisses. Appears at birth and fades with time. Require reassurance. It may show the outline into adulthood when the person become nervous or the skin become flushed. The next one is a stork bite, similar to salmon patch, but appears in the nape of the neck as a pink patch and decrease in intensity with time, but may persist also into adulthood. Next one is Mongolian spot. Mongolian spot is a blue-gray lesion. These lesions tend to fade over several years, but may not disappear completely. It is benign and require reassurance. No evaluation is necessary. The next one is milia. Milia is a cyst filled with keratin. Appears in the face, can appear in the gums, and also over the hard or soft palate. It is a benign condition and disappear or resolve with time, require reassurance. Another common benign newborn rash is sebaceous hyperplasia. It is raised lesions on the nose of the newborn. It is more yellow than the milia and results of maternal androgen exposure. It is a benign finding and disappears spontaneously, requires only reassurance. Cutis marmorata or mottling of the skin. You will see the skin here of different color, commonly seen in infants when they are cold and disappear when you warm the infant. Another common disorder in the pediatric clinic to presents all the time to pediatrician is diaper rash. One key word here, diaper rash. If there is no diaper, will be no rash. Irritant dermatitis or diaper rash because of contact with the moisture, for example the urine, friction with the diaper, or especially when the parents change the brand of diaper, or contact with the enzymes in the stool. The stool is very alkaline, and even few minutes can cause severe skin irritation and diaper rash. The description of the rash is erythematous patches that involve the convex area, where is the contact with the diaper or the moist or the stool. And the inguinal folds in this case will be spared. So the skin in the folds on the inguinal folds will look normal, but you will see the erythema on the convex area or the area where is the contact with the diaper. The management in this case, if you know the cause, you will know the management. So a frequent diaper change is very important. Change the diaper immediately when there is a stool. This will help to decrease the severity of the rash. Using high absorbable diapers to absorb the moisture also can help. Topical barrier cream, like for example zinc oxide or ointment, every diaper change. Also air exposure or giving some free diaper time will help a lot and will allow the skin to heal more quickly. This is a 3-month-old girl with a diaper rash. So this is a diaper rash. Here is not really obvious because of the cream the mother placed, but you will see here satellite papules all over, and the skin fold here is involved. Also here the same is satellite papules, red papule, and erythema of the surrounding skin, and the skin fold here is involved, is not spared. So what is the most likely diagnosis? This is a classic presentation of diaper candidiasis or a fungal infection in the diaper area. The species is Candida species. The clinical presentation, you will see erythematous patches that involve the convex area and inguinal creases as well. So different than the contact. The contact involve only the convex area, but the inguinal creases will be spared. Satellite papules and pustules you will see, and you will see scaling at the margins of the involved areas. The management here is topical antifungal cream, similar also to the contact dermatitis, frequent diaper change. Air exposure will help for faster healing. You need to check the mouth for any child present with diaper candidiasis to rule out any associated oral thrush. If there is oral thrush, you need to treat with oral antifungal as well, plus the topical antifungal cream. This is a 2 months old with rash all over the body and excessive scaly head, and sometimes is much more than that and is well known as cradle cap. The description of the rash is salmon pink color behind the ears, under the axilla, in the inguinal creases, and the rash also is greasy. It is covered with greasy scales. What is the most likely diagnosis? This is a classic presentation of seborrheic dermatitis. The exact cause of seborrheic dermatitis is unknown, but it is suggested to be caused by a fungal infection well known as Malassezia furfur. Malassezia furfur also is another cause of tinea versicolor, but this is also a possible cause of seborrheic dermatitis. Will make a difference in the management. Clinical presentation of seborrheic dermatitis is a salmon pink patches, like we saw in the previous slide, with greasy scale that involve the convex areas and the inguinal creases. Also, the scalp, face, and the retroauricular area behind the ears, under the axilla, also can be affected. Management of seborrheic dermatitis because of possible cause of Malassezia furfur or fungal infection. Topical antifungal cream is a very important step in the management of seborrheic dermatitis. For example, ketoconazole cream or clotrimazole cream. Low potency corticosteroid 1% hydrocortisone is very important step also in the management of seborrheic dermatitis. The most important step is to manage the cause, to manage the oil or the cradle cap and remove the scales from the scalp by using oil to moist the scales, and then you brush these scales from the hair. Also using anti-seborrheic shampoo, for example ketoconazole shampoo or Selsun Blue, is very helpful also in the management and decreasing the amount of scales. If you are treating a patient with seborrheic dermatitis and the resistant to the treatment associated also with diarrhea and failure to thrive, you should think of complement deficiency C5, which is well known as Liner disease. Intertrigo is erythematous and superficial erosion located in the skin fold under the neck, under the axilla, for the woman under the breast, because of the rubbing of the moist skin, and this result in erosion. This can be secondary infected with candida species or even bacterial infection, for example streptococcal infection. Management is apply adsorbent powder to keep it dry. In severe cases might apply a low potency topical corticosteroid. Antifungal if it's candida infection, like in this case erythema surrounded with satellite lesion, or antibiotic if a streptococcal infection is suspected. Miliaria or heat rash. The first form of miliaria is Miliaria crystallina. From the name is a crystallina, it is a fragile, non-inflamed small vesicles filled with clear liquids. As you see it here in this severe case, these vesicles usually rupture within 24 to 48 hours and will leave white scale. There is no treatment is necessary. The next one is Miliaria rubra or heat rash because of excessive sweating and heat retention. It is described as red papules surrounded by erythematous skin, commonly seen in the fold area, like in the groin area, under the axilla, under the neck. And this is because of excessive exposure to the heat and sweating, like for example overclothing the child can cause that. If become secondary infected, and both forms can be secondary infected with a staph infection, the name will change to be Miliaria pustulosa, and you will see here small vesicles filled with pus. The treatment is avoid sweating and allowing the skin to dry and cool. Also oral antibiotic, anti-staphylococcal antibiotic is necessary for treatment of Miliaria pustulosa, but these two forms just allowing the skin to cool down. Avoid over clothing is preventive to prevent this condition. Applying cooling lotions is not necessary and does not change the course of the disease. Just cooling the skin prevents over sweating will help to prevent this condition. If the child develop pus in each vesicle or in the vesicles, you should give oral antibiotic covering for staph infection. Again, management of miliaria or heat rash. Avoid overheat environment and avoid overdressing the infant is very important. Provide cold bath or sponge bath and air-conditioned environment. Management of Miliaria pustulosa, this is the one requires antibiotic. Oral anti-staphylococcal antibiotic, for example, cefalexin. Nevus sebaceous of Jaddison usually appears at birth. It is a single area of alopecia, and the skin is orange color or yellow brown with the same texture of orange, so it has skin. And this is very important to make a difference between nevus sebaceous and the cutis aplasia. Cutis aplasia will be no skin, but this one, it has a skin but without hair and the same texture of the orange skin. Typically located on the scalp, and there is a small chance of malignant transformation, and most of the dermatologists recommend to remove this skin when the child is older during adolescence. It is not recommended to be removed in young age. Atopic dermatitis, or the famous name is eczema. Atopic dermatitis is a chronic inflammation of the skin. The causes, with exact causes unknown, but it is a combination of inheritance, so there is a genetic components in that, and environmental factors. Food allergies is less common but is possible, associated with atopic syndrome or allergies, like for example allergic rhinitis and asthma. So it's very important to take a medical history when you have a patient with atopic dermatitis. The classic presentation of atopic dermatitis is pruritus or itching. So the skin is very itchy and super dry. If you touch the skin of a child with eczema, even without erythema, you will see the skin is super dry. So hydration of the skin is very important. Excoriations that you can see here, abrasions and lichenification and thickening of the skin. So the eczematous area is thicker than the rest of the skin or the healthy areas. Pigmentation could be hypopigmentation or hyperpigmentation depending on the original color of the skin. Distribution of atopic dermatitis or eczema in infants and toddlers is more common in the face, trunk, and the extensor extremities. During childhood, you will see it in front of the elbow and antecubital area or fossa, and in the popliteal fossa behind the knee. During adolescence, will be more in the fold area or flexural areas, plus the hands, feet, face, and neck. And the pruritus is more, or the itching is more significant during adolescence. We have different types of atopic dermatitis. The first one, keratosis pilaris. Keratosis pilaris is a type of atopic dermatitis. It is papules with surrounding erythema and feels rough. Commonly seen on the upper outer arm, face, and thighs. Seen in the patient with dry skin and often improve with time. The advice to give the patient: avoid irritants, use keratolytics, for example lactic acid and urea. Hydration of the skin, for example using cream based not lotion, for example CeraVe. Another form of atopic dermatitis is pityriasis alba, or white patches in the face. It presents with small poorly defined areas of hypopigmentation, commonly located in the face. It is more prominent in the summer because of the darkening of the surrounding skin. The key here is skin hydration, reassuring the parents this is not anemia, this is just a dry skin and is a type of eczema. It is not itchy as the rest of the other types of eczema, but it presents with white patches in the face because of the dryness of the skin. Also, applying topical low potency hydrocortisone, for example hydrocortisone 1%, is very helpful, but you need also to teach the parents this may take long time to disappear. Another type of atopic dermatitis is ecthysis vulgaris, or scaly skin. It's a polygonal scales, as you see here, is a dry skin, most commonly involving the lower extremities, and spare the folds or under the arms and in the groin area, more commonly seen in the lower extremities. A strong association with asthma. Emollients and hydration is the key for the treatment. Also avoid irritants and fragrance based cream. Also avoid lotion. Lotion makes the skin drier. Another form of eczema is nummular eczema. It is unrelated to the other types of eczema. Is coin-shaped, is round, commonly seen in the lower leg close to the ankle. It is coin-shaped scaling or crusted plaque that may be hyperpigmented. Sometimes become secondarily infected. It is very important to differentiate that from the fungal infection. The eczema or nummular eczema is severely pruritic, very itchy, and also there is no central clearing. In cases of fungal infection, you will see a round infection with raised border and central clearing, and it can be slightly itchy but not as severely itchy as the nummular eczema. Nummular eczema is very, very itchy. Management of eczema. The most important step in the management of eczema is to keep skin well hydrated using emollients. Emollients, ointment-based emollients is preferred over cream. But if the patient cannot tolerate the ointment-based emollients, you can use cream. Cream, for example, Cetaphil, Eucerin, or CeraVe cream can be used. You can use it as frequent as possible during the day and before sleep, especially after bath when the skin is wet. So this is the cornerstone of therapy to break the cycle of itchiness and also to allow the stratum corneum, the outer layer of the epidermis, to regrow and keep the skin hydrated. The next step, which is very important, anti-inflammatory, topical anti-inflammatory corticosteroids. Corticosteroids is the base of in the treatment of the eczema. So ointment-based is preferred over cream-based corticosteroids. Used twice daily until the skin is clear. Then you can use the emollient by itself afterward, and the corticosteroid will be used as needed if there is any itchiness. Keratolytic agents like lactic acid or citric acid in the cases of ichthyosis vulgaris. Antihistamine is very important to break the cycle of itchiness. For example, using cetirizine or loratadine second generation antihistamine during the day because of sedation, and hydroxyzine at night. Hydroxyzine also will give some sedative effect and decrease the itchiness during sleep. This is very important to break the cycle of itchiness. Antibiotics if the skin secondarily infected. Allergen elimination when appropriate should be undertaken. Allergic contact dermatitis is very important to be familiar and able to recognize all forms of contact dermatitis, because simply if you avoid contact to the allergen, you will prevent this condition. The first form and the most severe form we'll discuss is the poison ivy. Poison ivy is a delayed hypersensitivity reaction because of contact to the poison ivy plants when it brushes against the skin. The patient will present with very itchy, linear, erythematous and possibly edematous rash. So this rash can be severely pruritic or mildly painful. Also, they may present with vesicles or bully in severe cases. The management here, of course, avoiding contact with the poison ivy, immediate washing with soap and water, antihistamine, topical or systemic steroids in severe cases. Another type of allergic contact dermatitis is nickel dermatitis. It is because of the contact of the nickel and metals directly to the skin. To prevent this condition, you need to cover the metals in the belt or in the button of the jeans to be directly in contact with the skin. So this is very important to prevent this condition. Meanwhile, you need to treat with corticosteroids and emollients. This can develop in the ear from the earrings and in the wrist area from the watches, and you will see the rash will take the shape of the contact material. The next one is perioral irritant contact dermatitis because of frequent lip licking. To prevent this condition, positive reinforcement, avoid punishing the child because of that, and also to apply Vaseline petroleum jelly or emollients very frequently to keep the skin moist and hydrated and to allow the skin to repair. And this condition will disappear with time. Another important type of allergic contact dermatitis is juvenile plantar dermatosis. It is erythema, dryness. As you see here, the foot looks very dry and the skin is very thickened. There is a lichenification of the skin and cracking. As you see here, some cracking. The skin is glazed, as you see here, very shiny, glazed appearance of the plantar surface in the weight bearing area, and the area where is no weight bearing is spared. This is classic and very important to recognize in the cases of juvenile plantar dermatosis. There will be a sparing also of the interdigital web space. Management of the juvenile plantar dermatosis is reduce friction, lubricate the dry skin, cover the cracks, and topical steroids for flares. Immediate application of emollients after removal of the shoes or the socks. Another very important dermatologic disease in adolescents can cause a lot of distress and depression is acne vulgaris. Very important for the physician to ask if the adolescent is having any concern about the acne or if it's causing him any distress. Even if the visit is not for the acne, you should always address if this is causing any trouble to the child. To make it easy to understand how the acne presents and how to treat, we need to understand the pathophysiology of the acne. This is the epidermis, this is the dermis, this is the subcutaneous tissue, this is the hair shaft, and this is a sebaceous gland. And the hair shaft is surrounded by keratinocytes. During adolescence, this sebaceous gland is more active and it produces much more oil than normal. And as a pathophysiology of the acne, the keratinocytes surrounding the hair shaft produces much more keratin than normal, and this keratin will cause obstruction. And when there is obstruction here and excessive production of oil, this will cause swelling, and this swelling will appear as a papule, and this papule is the comedones. And if the comedones, the head is closed, it will give you white head. If it's open, it will change the color to be black head. So initially it will appear as comedones or a small papule in mild cases of acne. With prolonged obstruction, this swelling will become more obvious, and also the flora in the hair shaft is Propionibacterium acne. It will cause secondary infection, and this secondary infection will produce lipase, and this lipase will change the fatty acid in the sebum to produce pro-inflammatory fatty acids, and this will cause a pimple or a pus and appears as a pustule, and when the pustules heals, it will change to be nodules in severe cases. This is how the acne develops. So you have two problems here: the secondary infection and the excessive production of keratin. So if you are able to reduce the production of keratin, and that's why we use vitamin A, you will help with the treatment of the acne. And also if you use antibiotic to kill this bacteria, also this will treat the acne. Clinical presentation of acne vulgaris now is easy to understand after the previous slide. It presents with closed comedones. What is comedones? Is a small papule. If the head is closed, it will give you white heads. If it's open, the color will change to be black heads, as in this case. So here is one papule is closed, and when it's open, it changes the color to be a black color. So this is a mild form of acne. It's not inflamed, just small papules of open and closed comedones. It can be, the acne presents varies from mild, moderate to severe. Inflammatory acne varies in size from small papule to cystic nodule, as we'll see in the next slide. Also can be associated with skin discoloration, red, violaceous, or gray-brown hyperpigmentation. And this, when it reaches this point, this can be very stressful to the adolescents and cause depression. This slide is to simplify different form of acne and how they present in different stages. The first one, closed comedones. Closed comedones simply is a small papule because of the retention of the sebum with closed head and appears white. When the heads break and become open, is well known as open comedones and appears as black heads. This is the most simple form of acne, and the topical anti-acne gel will be the treatment of choice in this case. And in more severe cases, when the papules become secondary infected, become larger, and it shows pustules or pimples, and the papules become larger and more inflamed and reddish, and this will known as papulopustules, and the infection because of the Propionibacterium acne. And this is patients will benefit, of course, from the oral doxycycline plus the topical anti-acne gel. In more severe cases, the patients will have all form of acne, closed comedones, open comedones, small papules, nodules, and cysts, and inflamed and also change in color of the skin and the scarring. This is the most severe form of acne, and these patients may benefit from the oral retinoids and also the topical therapy and oral antibiotic as well. After understanding the pathophysiology of acne and how acne develops, it's very easy to understand the management. You need to reduce the keratin production, and this is where you will use the vitamin A. So topical retinoids is the principal, and should be provided to the all patients with acne. All types of acne, they should have topical retinoids is the initial treatment. Oral retinoids only in severe cases. and also in selective cases. Antimicrobial is very important because you know the cause is P. acne or Propionibacterium acne. You need to provide antibacterial or antimicrobial. Benzoyl peroxide is antimicrobial and is very useful in the treatment of acne. Clindamycin also can be used, and erythromycin. Combination of topical retinoids with antimicrobial therapy as a first line therapy for almost all patients with acne. This is the best thing you can do as initial treatment, combination of topical retinoids with benzoyl peroxide. This combination is a great combination, should be provided to all patients with acne. Oral doxycycline, like for example in severe cases like papulopustular type, where there is pustules or infected nodules, is very important to use oral antibiotic to decrease the severity and speed the recovery of the condition. Hormonal treatment in female adolescents can be helpful. Very important not to use oral and topical antibiotics together, should be avoided. Do not use oral and topical antibiotic at the same time. Mild cases of acne can respond to benzoyl peroxide, a topical antimicrobial gel. It is safe and effective and can be used alone. Topical retinoids is very safe and effective to use in all types of acne and should be offered to all patients with different types of acne. It is the preferred therapy to be given. Can be also combined with benzoyl peroxide. Very important to tell the patient not to use it every night in the beginning, and to use it 2 to 3 times per week and increase the frequency as tolerated. Also, the acne may get worse before it gets better. So teach the patient what to expect so they do not stop the medication early, and they may see effect after a few weeks but not in the first few days. Moderate to severe inflammatory acne, oral antibiotic should be offered, for example doxycycline, but you need to teach the patient about the side effects and possible side effects of doxycycline and photosensitivity. Pubertal female with moderate to severe acne, hormonal therapy can be an option, especially if they require contraceptive as well. Severe scarring and refractory acne in adolescents, isotretinoin is recommended and is very helpful in severe cases, but very important to know how to use it. Very important for females to have a pregnancy test before using isotretinoin because of teratogenic effect. Fungal infections. Oral thrush is a very common presentation in the pediatric clinics. Is a common condition among young infants. It is a white plaque overlying erythematous base, can be seen in the tongue, gums, hard palate, soft palate. It is difficult to remove with the tongue depressor. If it is removable with the tongue depressor, it is likely to be milk. Also, in cases of thrush, the child may have irritability and poor feeding because of the pain and stomatitis. Management is oral nystatin, oral antifungal. You need to give it after feed, not before feed, because you want to have the topical effect of the medicine and not to wash it quickly with the milk. So it should be used after feed, not before feeds. If oral nystatin is not effective, you can use oral fluconazole. Tinea capitis, the keyword here, which is highly suggestive of tinea capitis, alopecia, loss of hair, or scaling even without hair loss. Occipital lymphadenopathy. So alopecia or scaling and occipital lymphadenopathy. The most common cause in US is trichophyton tensurans, fungal infection. Tinea capitis presents in 3 different ways: alopecia type, inflammatory chorion type, and seborrheic type. Alopecia type, the child will present with one or more of round, oval, partial or complete hair loss, as you see here in this picture. And also, if you look closely, you will see the skin is covered with the scales, and if you look more closely, you will see black dots because of broken hair. Next one, inflammatory or chorion. You will see here there is an area of complete hair loss, and there is a swelling, and you may see even in other cases the pus coming out from the scalp, and is deep suppurative buggy lesion on the scalp. This is well known as chorion. It represents inflammatory reaction to the fungi and occurs fairly late in the course of the disease. This is the most severe form of tinea capitis inflammation, and you can see even worse than that. This child received the treatment for about 6 to 8 weeks, and initially the area start to be clean, and then 2 to 3 months later start to have some hair growth. 6 months after, he had complete growth of the hair, and this area was covered all with hair after the oral treatment with antifungal medicine. This is the type difficult to diagnose in the tinea capitis, seborrheic type, because it mimics seborrheic dermatitis with dandruff, and you will see the patchy or diffuse whitish to gray scale. Alopecia may be subtle in this case, that's why it's not easy to diagnose, and the treatment here also will be the same. The child will require oral antifungal medicine. Management of tinea capitis. Very important to know and remember that the treatment of tinea capitis require oral therapy. Topical therapy by itself doesn't work. Oral therapy is the mainstay of treatment. So oral griseofulvin is the drug of choice. It is safe and does not require routine lab for monitoring if it's used less than 6 weeks. 1 or 2.5% of selenium sulfide shampoo or ketoconazole shampoo twice weekly to kill the surface organism and reduce the spread of infection. Incisional drainage of carrion is not necessary, is not indicated. So oral therapy will take care of that. You don't need to drain it. Oral prednisone may be used for 1 week in severe inflammatory tinea capitis carrion. Is very helpful in many cases. Follow up in 1 month after the beginning of therapy. You need to teach the patient that the hair may regrow, but it will take time. It may take months. Sometimes it never grow back. So very important to give them what to expect after the therapy. Tinea corporis. Tinea corporis caused by Trichophyton rubrum is the most common. It is a ring-like lesion. This is the key here. For tinea corporis is a ring-like lesion with raised and active erythematous and scaly border. So here you will see a border is more reddish and raised above the level of the skin, and with or without central clearing. The lesion is slightly pruritic, but sometimes not pruritic. To differentiate this from the nummular eczema, there is no central clearing, there is hyperpigmentation in the middle, there is lichenification and thickening of the skin, and is very itchy. So it's too different than tinea corporis. It may be single or multiple. You may see just one or multiple in the body. Management topical antifungal agents are effective. Systemic therapy, if there is multiple lesions all over the body, you need to use oral therapy. Tinea cruris. Tinea cruris is a erythematous patch on the inner thigh and inguinal creases. The border of the lesions are elevated and exhibit scales. The scrotum usually spared, as covered here. It may be intensely pruritic and scratching, leading to erosion, inflammation, and lichenification or thickening. The management, topical antifungal until the eruption resolve. Avoid tight fitting clothes, dry after bathing, and may use absorbent powder like tinactin. So the key here also is to prevent the cycle of itchiness. Also oral anti-itch medicine may help to prevent the recurrence of this condition. Tinea pedis is a fungal infection of the feet. It's fairly commonly caused by dermatophytes such as Trichophyton. There is 2 types, interdigital between the toes and moccasin or diffuse type. The interdigital presents with pruritic erythema, fissuring and scaling, and this, as in this case, and maceration of the skin in between the digits. Moccasin type presents with diffuse erythema and scaling of the plantar surface and the side of the feet. Management, topical antifungals applied until the eruption clears. The key here to speed the recovery and prevent this condition to keep the feet dry. Wear well ventilated shoes and sandals. Avoid socks until the healing complete. This is the key here to help with this condition. Tinea versicolor caused by Malassezia furfur, from the name, is a mix of hypo and hyperpigmentation of round and oval macules, mainly in the neck and the lower back, and they sometimes spread down to the abdomen. Sometimes they present just with hypopigmentation, and the parents may think it is vitiligo, but in the cases of vitiligo will be lack of pigmentation. In cases of tinea versicolor will be just a hypopigmentation. Hyperpigmented round oval macules, as you see in this severe case of tinea versicolor. Under the microscope, using potassium hydroxide, the Malassezia farfar will look like spaghetti and meatballs of short hyphae and spores. In the board, they like this part. Topical antifungal in mild cases is very effective. 2.5% of selenium sulfide lotion or ketoconazole shampoo. In severe cases, like in this case, required oral therapy in order to clear this pigmentation, but it takes time for these pigments to disappear, so very important for teaching. Onychomycosis or fungal infection of the nails caused by dermatophytes such as trichophyton is the infection of two nails is more common than the fingernail. Because of course wearing the socks, because of the moisture, and the fungus always likes dark and moist areas. Thickening of the nail is the key here for the diagnosis. Thickening of the nail, as you see here, the nails are thickened, are broken, are fragile, with yellow discoloration, and you may see some powdery, fine powdery scales. Oral therapy is generally required. Topical therapy for this case doesn't work. So do not try it, it doesn't work. You may add it, but oral therapy is the main treatment. So terbinafine is option to give. Itraconazole, fluconazole also can be used for treatment of onychomycosis. Topical therapy may be used for superficial white onychomycosis. Recurrence is common. This is very important to tell the patients what to expect. Infestations. Scabies is a skin infestation by Sarcobatus scabii. It is spread by direct, prolonged skin-to-skin contact. It is not enough to catch scabies by just examining your patient. This requires people living together and prolonged contact. Pruritus or itchiness is the key for the diagnosis of scabies. It is more intense at night, where the Sarcobatus scabii is more active. Common location in the wrist area, ankles, the axilla, waist, groin, palms and soles. Scalp involvement may be seen in infants. The patient will present with papules, as you see in this case, burrows, which is white, gray, thread-like lines, may present also with vesicles and pustules. Very important to know about scabies: lack of family history or positive family history does not rule out scabies. So you may have only the patient or one family member is affected by scabies. So very important to keep it in the diagnosis, and do not let the negative family history mislead you or take this diagnosis away from your differential. It's very important. Also, the case may be very difficult to diagnose in neonate, as the rash may present or look different. Management of scabies: all contacts, all the family members, all the close contact and the household must be treated, even if there is no symptom. 5% permethrin cream should be provided for, and the patient, all household member, they should apply it from head to toe, and the cream should stay in the body for at least 12 hours overnight. Then they take a bath in the morning, and 2 courses required, so they repeat the course of 5% permethrin cream the same way, 12 hours overnight after 1 week. Severe cases may require oral therapy. Cleaning is the key. Thorough cleaning of all dirty clothing, towels, and the sheets of the bed and the car seats covers is important. So cleaning is the key. Hygiene is the key. Head lice. Infestation of the human head with pediculus humanus capitis is very distressing to the child, especially in school. Transmission via head-to-head contact, like wearing hats and sharing helmets. Eggs or nets and adult louse on the hair shaft can be seen. Regional lymphadenopathy also can develop. Management is permethrin 1% is the first line. Malathion lotion is highly effective as a second line option because it kills the egg. So this one is ovicidal, is more effective than permethrin. Psoriasis. Psoriasis is likely results from genetic predisposition. It is a well-defined, as you see here, well-defined papules and plaques. This is a plaque covered with a red, white, silvery scale. Removal of the scale, as in this case, will leave spots of bleeding and is well known as Ospid's sign. They like this in the board for some reason. Lesions appear in the areas of trauma, which is well known as Kobner phenomena. Nail pitting or thickening can be seen. So you need to look at the nails for children presents with psoriasis. Commonly located in the scalp, elbows, knees, umbilicus, and gluteal cleft. Management of psoriasis: topical steroids, first line of treatment. Photochemotherapy, ultraviolet A therapy alone or with psoralen. plus the ultraviolet A therapy, which is well known as PUVA. So PUVA is the P is the psoralen and UVA. Methotrexate in severe cases and resistant cases. Pityriasis rosea is a benign self-limited condition believed to be viral. Human herpes 7 is a possible cause, but the exact cause of pityriasis rosea is not known. Presents with oval, round, macular raised scaly lesions and the long axis along the cleavage on the back. Giving you the distribution of the Christmas tree. The new lesion may appear in 2 to 3 weeks. Very important for education. Also very important and critical for education that the rash may last for even 2 months. So the parents, they do not go from one office to another seeking help for this rash to go away and just require reassurance. So the exact diagnosis is very important. Reassurance is the first line of treatment, and emollients may be applied or even oral antihistamine as needed for itchiness. Differential diagnosis is very important. This rash can be mistaken with secondary syphilis. So very important to take accurate history of or sexual history in adolescence, because secondary syphilis will require aggressive treatment. In cases of pityriasis rosea will require only reassurance. Infantile hemangioma. Very important to learn about infantile hemangioma. It is the most common benign tumor in infancy, typically become evident around 1 to 2 weeks of age. So the child may be born with no hemangioma, then start to appear afterward with growth phase. So it start to increase in size and become more obvious in the first year. So you have to teach the parents it may get worse before it get better. This followed by plateau phase, stays the same for a while, then spontaneous involution where the hemangioma start to disappear. 30% disappears by 3 years and 90% or more by 10 years of age. So education about infantile hemangioma is the key. Superficial hemangioma, bright red dome-shaped papules or plaques, or even larger than that as a tumor. It feels like rubbery and may compress to palpation. Deep hemangioma will be blue-purple subcutaneous nodules or a large mass. This is a capillary strawberry hemangioma on the back of a 7-month-old boy. Very important, when any hemangioma in the back, you have to have MRI because possible extension to the spine. Infantile hemangioma, you should be familiar with the possible association with infantile hemangiomas. A beard hemangioma or hemangioma in the neck area may present with biphasic stridor or hoarseness because of extension of hemangioma to the larynx. Direct laryngoscopy is indicated if airway hemangioma suspected. Faces syndrome, clinical finding here, posterior fossa defects, hemangioma, arterial anomalies, cardiac anomalies, aortic coarctation, eye abnormalities, sternal cleft, supra-umbilical abdominal raphe, which is a white color or light colored ridge tissue between the umbilicus and the sternum. Lumbosacral hemangioma may be associated with occult spinal dysraphism or spinal cord defect. So any hemangioma in the lumbosacral area, the child must have a MRI imaging to screen for this association. Management of infantile hemangioma, teaching the parents about the course of the illness, that the hemangioma may look worse before it get better, and it may take few years to disappear. Topical or oral antibiotics if ulceration or secondary bacterial infection. Beta blockers, propranolol, reduces the severe hemangioma in infants. Topically applied beta blocker timolol is very helpful for small facial hemangioma. Pulse dye laser therapy if ulceration or early superficial hemangioma. Surgery in severe cases. General indication for treatment if affecting vision or breathing to prevent complications, especially if it's located in a high risk area of bleeding or trauma. Minimize psychosocial distress. So this is general indication for treatment. Capillary malformation. You need to know the difference between the salmon patch and port wine stain. Salmon patch is well known as nevus simplex, stroke bite, or angel kiss. We discussed that in the beginning of this presentation. It is a dull pink macule or patch commonly seen in the nape of the neck, in between the eyebrows, in the forehead, or above the eyelids. Usually fades by 2 years, require reassurance, may be seen later in life when the child is crying or is training. Port wine stain is different. Port wine stain is well known as nevus inflammus. As you see here, this nevus inflammus or the port wine stain is a capillary malformation of the skin. It persists throughout the life and grow as the child grow. The port wine stain commonly isolated condition. It is very important to know that not all the port wine stain associated with the Sturge-Weber. Actually, it is most common to be isolated condition and not associated with the Sturge-Weber. But Sturge-Weber syndrome must be in the differential because of the complication. Management of port wine stain can be treated effectively with pulse dye laser, and it offers effective cosmetic palliation. Very important to check the eyes to rule out the association with the Sturge-Weber syndrome. This child is having Sturge-Weber syndrome with port wine stain, but most commonly is isolated condition. Very important to keep that in mind. Kasabach-Merritt syndrome is a vascular tumor, can be associated with thrombocytopenia, hemolytic anemia, and coagulopathy, as opposed to the infantile hemangioma, which regress over time in the first few years. This tumor do not regress spontaneously, especially the Kaposi-form hemangioendothelioma. And this tumor is localized tumor, however, can be very aggressive. So this tumor do not metastasize. This tumor also can be fatal. For any infant who presents with unexplained thrombocytopenia, you should keep the vascular tumor in differential, because this tumor can be easily identified under the skin, but also can be hidden in the viscera, for example in the spleen. So very important to keep in differential for any infant who presents with unexplained thrombocytopenia, because this can be fatal. Papular urticaria. Papular urticaria is associated with insect bite. And after the insect bite, the child might develop crops of symmetrically distributed pruritic papules, and these papules may become vesicles or papulovesicles. Papules and vesicles together can be at the site of the bite or in many different sites. So you can have one bite in the arm and the rash appears all over the body. Scratching may produce erosion and even become secondary infected. After the resolution of the rash, it may leave a brownish pigmentation afterward. Management of papular urticaria: mild topical steroids and systemic or oral antihistamine to prevent or to help with the itchiness. Rarely oral steroid is required in cases of papular urticaria. If secondary infection developed, for example in vitiligo, you need to use a topical or a systemic antibiotics depending on the severity. Use of insect repellents or prevention of insect bite is the most important while the patient is outside, and for the indoor use flea or tick control for indoor pets. Erythema multiforme: 50% of the cases are idiopathic and the cause is unknown. Sulfa drugs are the most common drug triggers erythema multiforme. Herpes virus infection is the most common infection triggers erythema multiforme. The patient may present with a typical target lesion or atypical target lesion with central clearing. They may develop papule vesicles or bulla in the middle of the lesion. It is associated or can be associated with mucous membrane involvement, but will be just one mucous membrane. Extensive mucous membrane involvement, more than one, will change the diagnosis to be Stevens-Johnson syndrome. Body surface area affected is less than 10% and the treatment is supportive. Of course, if the patient taking sulfa, you need to stop that, and if the patient is having herpes virus infection, you need to treat. Stevens-Johnson syndrome is more severe than erythema multiforme. Common triggers: medication, sulfa medication, anti-epileptics, infection, for example EBV or mycoplasma. Presents with flat atypical targets, blisters and erosion, as you see here. Also associated with severe mucosal erosion, usually two sites or more, for example eye, mouth and esophagus. Body surface area is less than 10%, usually require hospitalization in burn unit or PICU if is associated with extensive erosion. Using IVIG is controversial in cases of Stevens-Johnson syndrome. Toxic epidermal necrolysis: this is much more severe than Stevens-Johnson. Medication, for example anti-epileptics, trigger this condition. No typical targets. They may present with flat atypical targets and diffuse generalized detachment of epidermis. So this is more severe, like very similar to the patients with severe burn. Severe mucosal erosion as well. Body surface area affected more than 30%. This require all the time admission to intensive care and burn unit for electrolyte adjustment and prevention of secondary infection, similar to the management of burn. Removal of offending drugs is the key. Fluid and electrolyte maintenance, IVIG should be considered in this case. Impetigo is very common in pediatrics and is very highly contagious and commonly caused by Staphylococcus aureus. This is the most common cause of impetigo. Streptococcus also can cause impetigo as well. Presents in bullous or non-bullous impetigo. Appears as honey crust. This is the most common presentation, honey colored scab from the dried sebum, commonly around the lips, also under the nose, on the face, also can be located in other areas in the body depending how the child inoculate the infection with the fingers. The management, very important to know, it is very highly contagious. Managed with topical anti-staphylococcal antibiotic, for example miobricin ointment, applied until the lesions are all clear. If extensive lesions in many areas, you need to give oral antibiotic or even IV depending how extensive is the lesion. Back to school when all crust are dried because of to prevent the spread of infection. Very important to know, streptococcal impetigo can be complicated with glomerulonephritis. Molluscum contagiosum, from the name it is contagious, caused by DNA pox virus called the Molluscum contagiosum virus. It presents with flesh colored, as you see here, dome shaped and pearly appearance with central depression or umbilication. It can be single or multiple in many areas of the body. It is highly contagious, should be covered and to prevent the spread of infection to others. You need to teach the parents that it takes time to go away. Avoid scratching, avoid shaving or trying to remove, because the more they remove it or they break it, it will spread to other areas of the body. If cosmetically or psychologically distressing, then mechanical removal, but generally it will resolve by itself and will go away with time. It takes a few months to even few years. Wart is a viral infection caused by human papilloma virus. Genital condyloma acuminata or genital wart. This type of wart increases the risk of anogenital cancer, appears in the genital area. Appearance of this type of wart in children is considered child abuse. Verruca vulgaris is a common type of wart in children, is disfiguring, appears in the fingers and arms and legs. It is hyperkeratotic papules with rough and irregular surface, looks like cauliflower. Deep palmoplantar warts. This type of warts is painful, grow deep, so it is deeper than it looks, and it tends to be more painful, especially the one in the foot as they walk. Flat warts is a flat or slightly elevated smooth flesh colored papules. Management of wart, as you see here, this wart in the palmar area, it is much deeper than what you see. It is usually tender, and also in the foot it is tender and it can affect the walking. The treatment or the management is cryotherapy to freeze it after application of topical anesthesia for comfort. You freeze it and you make sure that you affect the healthy surrounding tissue, and you keep it to make sure that the freezing extended to the deeper tissue, and then after that it will slough and go away by itself, and it will heal in most of the cases. Also another option, electrodissection, curettage, surgical excision, in rare cases, carbon dioxide laser treatment. This is options with the most commonly used option and is easy is cryotherapy. Alopecia areata. Alopecia areata is hair loss with small bald patches, as you see here, and the skin here is very clean, very clean. There is no scar, there is no scaling, there is no black dots. So there's a big difference between the alopecia areata and the tinea capitis. Tinea capitis, the skin is dirty, is covered with the scales and the black dots because of fungal infection. In this case, the skin is clear and clean, and there is no hair in the alopecia area. It is considered autoimmune disease. Localized hair loss, alopecia areata. Totalis, loss of the 100% of the scalp hair. Universalis, of loss of 100% of the body hair of the entire body. Management reassurance, and steroid, topical and systemic, can be helpful in some cases. Trichotillomania is a condition because of self-induced hair loss. So the child is pulling the hair, and sometimes even they swallow it, and can cause trichobizor or abdominal pain or obstruction. Associated with stress and anxiety, the key here is you will see the hair in different lengths, as you see here in this figure. They pull the hair of the scalp, sometimes the eyebrows or eyelashes. They most of the time they do it in private, and they deny this behavior. If you confront them, they are pulling their hair. The management here, counseling or psychiatric evaluation is necessary. Telogen effluvium is a hair loss secondary to significant stressful events. Makes the hair prematurely goes to the telogen phase. Usually you have a few three phases: anagen and catagen and telogen. The anagen is the hair growth, and the catagen is a short transition stage that occur at the end of the anagen stage. And then the telogen is the resting phase, and where the hair start to fall. Between 50 to 100 hair usually fall per day. If the person goes through stressful events, about 70 or even percent or even more of the hair will be prematurely goes to this stage early and cause significant hair loss. This can be associated with stressful events like weight loss, major illnesses, surgery, traumatic psychological events. Stress triggers more hair into the telogen phase prematurely, causing diffuse hair loss that peaks approximately 3 to 4 months after the stressful events. So history here is the key. Management is reassurance. Anagen effluvium is loss of growing hair during the anagen stage. Anagen stage is the stage where the active growth phase of the hair follicles causes chemotherapy. So common in children with cancer receiving chemotherapy, and occurs 10 to 14 days after the insult. So the management reassurance: once the chemotherapy stopped, the hair will come back again. Very important to make a difference between the anagen effluvium and telogen effluvium. Telogen is because of stress events and occurs a few months after the stressful events. But in the cases of chemotherapy, it will be anagen effluvium because affects the hair growth during the anagen phase. And this occurs 10 to 14 days after starting the chemotherapy. Once the chemotherapy stopped, the hair will regrow back. Malignant melanoma generally is rare in children, but start to appear these days, and it should be always in the differential. Sun exposure is the most common cause, especially during the business hours. Red flags, very important to know about malignant melanoma: the asymmetry or irregular shape, the border unusually changes in the border, the color also different colors, some areas dark, some areas are light, the diameter is more than 6 millimeter. These all are red flags of malignant melanoma. The management to prevent is sunscreen, early detection, and early referral is the key. Granuloma annulare is very important to know because can be mistaken with fungal infection or nummular eczema, but there is a big difference here with granuloma annulare. You will see here the thickened skin is ring-like lesion without a change or scales. There is no vesicles or pustules. Is very clean and also is not itchy, is asymptomatic. So this is granuloma annulare. Require no therapy, no medicine, just reassurance. It will resolve and go away by itself. So the management is reassurance. Incontinentia pigmenti is X-linked dominant disorder that presents only in females. It is lethal in males and boys. So it presents only in females. Stage 1 appears after birth with vesicles and erythematous base, can be mistaken with erythema toxicum, but the difference, this one is persistent and go through stages. Stage 2 will be wart-like papules. Stage 3 will be linear and swirled hyperpigmentation as you see here. Stage 4 hypopigmented atrophic streaks. Common associated problem with incontinentia pigmentia, alopecia, dystrophic nails, packed teeth, ocular abnormalities, seizures, and developmental delay. Management: there is no cure for this illness, only supportive topical antibiotic in vesicular stage, keratolytics for wart stage, consultation with ophthalmology, genetics, and dental. This is the end of my presentation. Thank you for listening. This lecture is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.